Hello and welcome to another series of MRCP teaching by Dr. Raza. Today we'll be talking about lymphopenia and the commonly asked hematological slides in the MRCP exam. So lymphopenia is a common finding in elderly, and if the lymphocyte count is greater than 500 cells per liter, then no action is normally needed. It can be caused by immunosuppressive drugs like methotrexate, viral infections like HIV, non-viral infections like tuberculosis and malaria, certain autoimmune disorders like rheumatoid arthritis, and lymphoproliferative disorders can also cause lymphopenia. Now we'll be discussing about the common blood films like the pathological cell forms that are commonly asked questions in the MRCP 1 and 2 exam. So the common pathological red cell forms are the target cells that occur in sickle cell and thalassemia. They can also occur in iron deficiency, anemia, hyposplenism, and liver disease. The teardrop poikilocytes are the hallmark of myelofibrosis. Red blood cells are mechanically squeezed out of bone marrow that causes teardrop cells. Spherocytes are typical for hereditary spherocytosis, as the name says, and autoimmune hemolytic anemia. Moreover, lead poisoning, thalassemia, sideroblastic anemia, myelodysplasia can cause basophilic stippling. Howell-Jolly bodies, if it comes in exam, it shows hyposplenism. These are the basophilic remnants of red blood cell nucleus. Glucose 6-phosphate dehydrogenase deficiency presents with Haynes bodies. Moreover, alpha thalassemia can also cause Haynes bodies. Schistocytes or helmet cells are the commonly asked scenarios in MRCP exam. It occurs due to DIC, mechanical heart valves, and intravascular hemolysis. Iron deficiency anemia can cause pencil poikilocytes. Uremia, pyruvate kinase deficiency, and liver disease cause Burr cells. It is an exhaustive list, but it is important to remember these, red cell films. So acanthocytes, they are caused by A beta lipoproteinemia, and the bite cells are caused by glucose 6-phosphate dehydrogenase deficiency, where the spleen removes Haynes bodies from the RBCs. So it is just a reiteration of what we have already discussed. So the typical pictures on the blood films are hyposplenism that can occur post-splenectomy, and it presents with target cells, Howell-Jolly bodies. These are the spherical bluish inclusions within the erythrocytes. The nuclear fragments, they are the condensed DNA normally removed by the spleen. There can be Pappenheimer bodies, siderotic granules, and acanthocytes in patients with hyposplenism. Iron deficiency anemia presents with target cells, pencil poikilocytes. Combined vitamin B12 and folate deficiency gives a dimorphic film that is mixed microcytic and microcytic cells. Myelofibrosis is characterized by teardrop cells, intravascular hemolysis, comes with schistocytes, and hypersegmented neutrophils are present in megaloblastic anemia. It is one of the scenarios that was asked in the MRCP exam, that is the congenital Pelker-Huijsen anomaly. It is a laminopathy due to the mutations in lamin B receptor, in which bilobe nuclei in the neutrophils occur. It is a homozygous disorder that is characterized by other skeletal abnormalities like shortened limbs. If there is a heterozygous disorder, then there are no symptoms. However, a neutrophil anomaly is an incidental finding in the heterozygotes. So this was the exam scenario, that is a 23-year-old man with tiredness was noted to have a neutrophil abnormality on his blood film with bilobed nuclei. His father had a skeletal anomaly with a short right arm. Examination revealed no lymphadenopathy and abdominal examination was entirely normal. So it was asked that what is the most common cause of this presentation. So congenital Pelger-Hui abnormality is the most common cause of all these abnormalities.